I'm Dr. Michael Totola.
And I'm Megan Strong.
On today's case of the week, the preps look good, but they don't quite draw. I think I got a possible solution for that.
And if you're looking for the perfect gift for the female dentist in your life, pop star Kesha might have the right thing for you.
And if you're looking for the perfect gift for a certain co-host in your life, take her out for a me day. We were plucked, we were buffed, we were waxed and shined, all that and more on today's Chairside Live. Hey now, welcome to episode 58 of Chairside Live. Morgan, how are you?
That is not my name.
What'd I say?
Morgan.
I meant Megan. Megan, how are you?
58 episodes and you still don't know my name.
No, I do know your name,
Okay.
but we would have been playing the name game. One of our news stories a little later today, I think I was focusing more on a certain singer's name that we'll get to later.
Okay.
I apologize for that.
It's okay. But I'm doing well. I'm hopped up on sugar. I made homemade caramel corn last night to die for. And so I've been just crazy on sugar.
Yeah, and you had me eating it a couple hours earlier.
I did.
I was on a total sugar high, started to crash. Two choices. I could nap or come back strong. I've come back strong with the coffee and a couple donuts and a little more caramel corn. So I, too, feel like I'm pre-diabetic at this point, but super awake at the same time.
Nice.
So thank you. We've got an interesting case of the week for you guys this week. It's a BruxZir bridge prepared by a dentist. And the preps actually look really good. It's the fact that the path of insertion is not ideal. In fact, there's going to need to be some modifications to one of the preps if this bridge has any chance of working. And I think we have a novel way of helping the dentist accomplish that. In fact, let's take a look at that now. I was walking through the all-ceramic department the other day, actually looking for one of my cases, and I happened to see this case with some paperwork that was sitting there, and it's an interesting case because it's a nice-looking case. It's a bridge that's being done here on the lower left, and the doctor has prescribed a BruxZir bridge here. And again, just to, there's nothing wrong with prescribing a BruxZir bridge here. Personally, this would probably be a situation where I might opt for a PFM bridge, only because of the fact that with that metal framework underneath it, that's still the strongest bridge we have. In fact, the strongest bridge we have would be a cast gold bridge with no ceramic material on it from here to here. Unfortunately, that would cost the lab cost, or the cost of the patient would be the equivalent of the GDP of a small nation. But also, it would not be very aesthetic, and it would weigh about 4 pounds. When you look at it, the doctor did provide enough clearance for us, occlusally, which is nice. You can see, though, we've had a little super eruption of that molar. You may have heard me say that I haven't done a single unit PFM since about 2009, really since the introduction of BruxZir. I either do Emax restorations in the anterior for the most part, or BruxZir restorations in the posterior. But when it comes to bridges like this, I still think there is a use for PFM bridges, because even though BruxZir is strong and we can hit it with a hammer, it's still an all-ceramic restoration. And you'll notice that in the hammer video, we hit a single unit with a hammer, not a bridge. And it's these kind of spans here where there is a possibility that the BruxZir material can fracture. So, you know, really nothing wrong with prescribing a BruxZir bridge here, but I would just say to you that if you're wondering if there's still a place in your professional life for PFMs, this is where I would say it is. But you can see the doctor really has given us some nice margins. I mean, really just fantastic margins. It almost looks like it was prepped on a Typodont, in fact, that it looks so nice. But as we rotate this over and look at it from the occlusal, you'll notice that as we look down the path of insertion, that we can see no undercuts on the bicuspid, but we're not able to see that mesial lingual section. And this is one of the neat things for us about being able to scan in terms of CAD/CAM, be able to take a model like that and then be able to take it into our software and scan it, because as we scan it, we can see that there's clearly an undercut, and we don't have to just eyeball this. You know, we can actually measure now where the undercut is and say, okay, we can see these green dots as we mark the margin all the way around, then the green dots disappear. Then we can rotate, and the software actually marks for us exactly where the undercut is. You know, here's the undercut and here's the extent of it. And so the question becomes, how do we pass this information on to the dentist? What we'd like to be able to do is not to have you get the patient back and re-prep this area, then have to take another impression and send it to us. I mean, certainly that'll work, but just in terms of saving an appointment for you and the patient, what if we could take, this information and transfer it to you and make a bridge for you and send it to you if you wish, so that you could try to make this adjustment and make the bridge fit. Some dentists aren't comfortable doing that, and that's fine. Sometimes we as a lab aren't comfortable doing that either, and frankly, you'd probably have to ask for it. And you might even have to pay for the remake yourself, if you weren't able to do this. That's may not be the lab's opinion, but that's certainly my opinion as an individual. But what if we gave you a way that was more predictable to be able to reshape that and get rid of that undercut? So we can do that today. In fact, as we look at this, again, we can see the original model where we're not going to be able to draw because of the undercuts along here on the mesiolingual, what was clearly identified, again, by the diagram right in here. So one way to do that would be to make a prep guide, and this is in fact the prep guide. This represents that same case, but now those undercuts have been removed, and when we go in and scan it, at this point we're able to see that we no longer have any of the undercuts that we have before. In fact, here is a scan of that prep guide that I just showed you on the stone model. And now when we look around, we can see the green dots marking the margin all the way around, and we can in fact see them, and we have the insertion direction marked as well. And now all of a sudden we've eliminated all those undercuts that we had here. Same scan, same software, and it tells us that it's now gone. So this is what the doctor needs to do, essentially move from what we have here to what we have here. And you don't have to touch the bicuspid at all. As it turns out, it's just the molar that needs to be prepped, just the mesiolingual of that molar. And so the question becomes, how do we best communicate that to the doctor? You'll notice we really haven't reduced anything on the occlusal surface per se. You'll see a big difference between the slope on the mesial part of that prep versus on the prep guide over here. Obviously how that's slanted back much more towards the distal. And that's really the only area where we've lost any occlusal height, if you will, is by having to taper that mesial wall back towards the distal. And so the question becomes, what's the best way to let the doctor know just how much has to be reduced? And so there's a couple things that typically will have the lab do for me in a case like this. And the first one is, well, a reduction coping would typically be a good way to do this. We just happen to make this one out of zirconia. Typically on a reduction coping, we'll use that for when a cusp tip is too long. So for example, if we didn't have enough clearance, let's say, on this bicuspid and we needed some of this cusp tip taken off, we would have a zirconia coping that would fit around the tooth. It'd have a hole in it. Part of the tooth would be sticking out of there. And the doctor would be instructed just to prep the tooth back until the preparation was now flush with the zirconia coping. As simple and as useful as that sounds to me, you'd be surprised how many times we send doctors reduction copings like that, and for whatever reason, the reduction that's necessary is not done. I'm not sure if it's just a lack of understanding about how to use a reduction coping. Maybe dentists think it's a suggestion and not an absolute kind of thing, but this is a zirconia coping that's fitting down onto our new prep guide on that molar. The problem is, unlike with the cusp tip, where it sticks out of the top of the reduction coping and shows you where it needs to be prepared, this fits on top of the entire preparation, and now it will go down into place, and you can see it on the margins that it will be closed. But it doesn't show you, it doesn't give you that physical guide of, hey, drill here kind of thing. And so what we would end up doing would be marking this area for you so you could see that, and I kind of polished that away as we prep this model where we had it marked before. But we would mark it with a marker and say, here's the area, or we would send a copy of that scan that you saw originally that showed the undercut on the mesiolingual and say, this is where it needs to be adjusted. But this single kind of coping is a little difficult to work with. So what I had the laboratory do, and what I think is a good idea, is to have something that's a multi-unit like this, because now we have a handle where we can actually grab onto this while it's on the prep guide. And you'll notice on that bicuspid it stops short of the margin. Why is that? We want a clear, visible physical stop, I should say, as we push this down into place on that bicuspid. So just in case the tissue is collapsed a little around that margin, or maybe there's a little bit of bleeding, we want the dentist to be able to know that is seating all the way as I push this down, because I can see it clearly against the prep here. And now you know when you've reduced enough, because you can take this in and out. And essentially, this is the zirconia framework that's going to be inside your bridge. Or for that matter, if you were doing a PFM bridge, we could do this as well. The one that you might get from us could be printed, could look like this, where it's printed actually on a 3D printer. We have a lot of 3D printers here at the laboratory, and so this is an easier way for us to be able to print this, and a little less expensive probably. But in this printing, it's just a little more difficult to see on film, you know, in contrast with the yellow stone. So I had them actually mill a zirconia one for me. And it could go either way, but in the mouth you could see how the white one might be a little more difficult to maybe see on the teeth versus, say, the orange per factory printed one, which might stand out a little bit more. So you could get, you know, one or either of these. And essentially you're going to end up with a model showing you where to prepare, in this case on this mesiolingual surface of the molar, and then it's a matter of continuing to try this in until it goes down all the way. Now, if you were actually trying the bridge in here that's going to fit on here, you can imagine it might be a little more difficult to visualize because of the way that the margins might be slightly subgingival. And so that's the reason I like this way of doing it, where the margins are trimmed a little bit short. This makes it easier for you to be able to see whether or not you've reduced enough, in this case on the molar, to get rid of the undercut. In fact, you could try this in and out on the model like this, and then take it right into the mouth to check and make sure that it's seating the same way in the mouth as it's seating on the model itself. With the bridge itself, as you push it down, you would kind of get a feeling for that, but it makes it a little easier just to drop this in real quick and see how it's seating, and then reduce a little more. And then when you get close, you could take the actual bridge, and what you'd like to see when you drop the actual bridge in is that when you check this contact, it felt good. When the patient bit together, the inclusion was good. That would be two more signs that you had, in fact, reduced enough, and now the undercut was no longer a problem. And as you might expect, if we take that same prep guide zirconia framework and try it on here, it's going to fit on the bicuspid very well, because the bicuspid has had no modifications to it. But of course, it's not going to fit onto that molar. And that gives you an idea of how much tooth structure had to be removed there. If you looked closely at that scan that I showed you before, you could see that that mesial wall of this molar, instead of being like it is here at about this angle, ended up being tapered, you know, back like this. And that's where we lost a little bit of that height. And that's exactly what needs to be removed for this to seat down all the way, and then for the permanent bridge to have a chance of seating down all the way. So you really have two choices. You could have the patient back at this point, and you could say, oh, we need to go in and do a little more. They scanned at the lab. They have these scanners that we don't have here in the office that I need to go in and reshape this back tooth to make sure this is going to work. You could also say, I don't want to reshape that tooth that much. I tell you what, let's quickly drop 2 implants in right here. If you get the patient to go for that, and then do 2 single unit crowns, I know that'd be a stretch. That'd be a little difficult to get a patient to say yes to that on the spur of the moment. Or you could take a chance and have us make you the actual bridge itself, and maybe one of these prep guides at the same time, and then slowly, you know, you would put this on and then make your corrections here on the mesial and mesiolingual portion of that molar as you continue to try to drop this into place until you saw that eventually it went down in the mouth like this, like it did on the prep guide. Then try the permanent bridge in, and hopefully with no contact issues and no occlusion problems, you would know your bridge is all the way down, and you saved yourself an appointment at the same time. This is certainly possible to do. You know, you need to anesthetize the patient, and you need to be committed to get this seated all the way. You know, when you look at that molar and how much preparation's been done on that, there's been a lot of preparation to get it from where it used to be to get it to this point here. But if you're going to do a zirconia bridge without any kind of a attachment or stress breaker there or telescopic coping, this is what needs to be able to be prepared to get that down and get that bridge seated in one piece. And we're more than happy to show you how to do it, whether or not you want to do it in a separate appointment or try to seat it at this point is up to you. But certainly with the use of 3D scanning that we have here at the lab, we can accurately identify any undercuts that might be present and show you exactly where they are on the scan and then fabricate something for you that's going to help you.
Thank you, Dr. Frankenstein.
You're welcome,
Now
Andy.
let's go to a segment we call Viewer Mail. This week's Viewer Mail comes to us from Rachel in New York, and she writes, Dear Dr. Datola, my name is Rachel, and I'm a dental assistant in the New York region. I'm writing to you today because I think Chairside Live is such a great show. My dentist that I work with watches every episode of the show, and sometimes I join in and watch a little bit here and there.
Well, I try not to interrupt
Sure.
while you're reading these, and I usually don't, but she's a huge fan, but she just watches a little here and there.
Right. Come on, what are we doing? Are we not good enough for you?
We're not asking for that much of a time commitment,
No.
right? This isn't like a full weekend or a bunch of episodes of like Mad Men back to back. Okay, but all right.
Okay.
I'm all right with that.
We'll
But
continue. You and Megan are very funny, and
Sure.
you make a great team.
yes, we do. In fact, yesterday we got manicures together. We did.
Isn't
Because
it
I don't know if
cute?
you've noticed, but on the case of the week,
We all have noticed.
Oh,
Sorry.
well, on the case of the week, my hands have looked not unhygienic, not disease-ridden. That's a little strong, but they just haven't been as nice as they could look. Like back in the old days before dentists wore gloves, my dad used to get manicures because you'd be sticking these things right into people's
Ooh,
mouths.
wow.
And now with
Yeah.
gloves, you don't have to, but we've cleaned it up. So yeah, we got a manicure together.
We did.
We bonded over that. I thought it was fun.
Oh, yeah, we really did. Okay, so we're going to continue. I watched your video on shading and simply love your all A2 shade guide. I thought that was so funny.
It is, and it's patented. Don't use that in your practice without paying me a royalty. Okay.
Is there any way you guys could send my dentist a mug and a signed picture of you and Megan? He loves you guys, and it would be a great surprise for him. I'm not sure if you do things like that, but it would sure make him happy. I don't want to push my luck, but if you could give a shout out to him during the show, he would be thrilled. His name is Dr. Wallace. He's a great dentist and really loves what he does. Congrats on 50 shows and many more to come. Rachel.
Well, thank you for the congratulations on our 50 Shades of Chairside Live, or 50 shows, or whatever she said. And is that pushing her luck, you think, asking for both those things?
No, I think for such a sincere, heartfelt letter of a dentist who loves watching us, I feel like that's
I agree.
totally
I
okay.
agree. So we're doing it for Dr. Wallace because he
Right.
watches it from start to finish.
Yes.
He doesn't like poke his head in for 5 to 8 seconds like Rachel
Or
does.
just-
Get bored and then walk out.
Sure, or just tune in for the bloopers. No,
Right,
he's
exactly.
there for the long haul.
For the long haul.
Yeah.
All right. So let's do this. Dr. Wallace, thank you, first of all, for being a loyal listener. Congratulations on loving dentistry and loving what you do, putting up with Rachel. And no, I'm just kidding, Rachel. And so what we'd like to give for you is exactly what Rachel mentioned. We have a photograph that we're about to sign live. I'm going to, if I can, see if there's any of Megan's kettle corn left over. I'd like to see a tiny little baggie be
yeah.
sent along so they can experience the same sugar high. Hopefully, in fact, stop the show right now if you're watching. Eat it all at once like we did. Wash it down with a little black coffee, and you'll be
Good to
at
go.
our energy level. The same way. And we'll also send you one of these mugs, probably a clean one and not the one sitting right in front of me. But glad to have you on as a fan, and glad to know that you're there week after week. We're starting to hear from more offices, believe it or not, that actually watch the show
Yes.
on their lunch hour. I mean, this is we've become their entertainment on an otherwise slow Wednesday afternoon, I suppose.
Pressure's on. We have to be really entertaining.
Exactly. So while their TV dinners are reheating in the microwave or whatever they're having for lunch,
Lean
we get to
cuisine?
be their entertainment, which I think
Yes.
is fantastic.
Yes.
All right. Thank you. You have any news stories for us today?
I do. In 2012, Nashville pop singer Kesha asked fans to send her their teeth, and over 1,000 of them came pouring in. She made them into earrings and a bra. Oh, but she's not done yet. The singer is now coming out with a line of jewelry called the Cannibal Collection, which features gold casts of human teeth. How about a bracelet, earrings, or a ring with the dental decor? Well, maybe if you're not into human teeth, how about animal teeth? Kesha's Animal Collection offers a cast of fossilized shark teeth. You can look for the jewelry to hit stores in August 2013 and expect to pay anywhere from $30 to $500.
Wow. I'm not with it, as the kids say. I don't know who she is. I don't know that I could name one of her songs. I do. The only thing that I know is from when you sent me the news story that the S in her name is like a a dollar sign.
Yes, it is.
Which is it's kind of a power move. In fact, I wish I had an S in my name. I don't. You do.
I do.
I'd like to see Megan strong with the S as a dollar sign.
It would be incredible.
Right.
Yeah.
Pretty sweet. You might even get yourself a raise here on this here show if you were able to do that.
Let's do that.
But I don't know anything about her. James just put up this picture for me so I could take a look at her. A little scary.
A little bit.
I'm slightly intimidated, and it didn't really go into detail when she said she was asking fans for their teeth. Are we talking baby teeth that came out when they were young, or wisdom teeth, or just the odd numbered teeth, or what? Are they taking out permanent teeth and sending them?
It didn't say, but that was exactly what I was thinking of. I don't have any of my teeth lying around. Like,
right.
I didn't save them. In my mind, the tooth fairy took them, remember? Like a long time ago. So honestly, this has got to be the strangest thing because, as you mentioned, are they pulling the teeth?
Right.
What is happening? And if they aren't pulling the teeth and they just happen to have them lying around, that's weird.
That is odd. And as you know, I have 200 teeth lying around on my desk that I accidentally ordered from India. I meant to order them from Canada, and they came from India, and I feel somewhat guilty about the legality of that whole thing.
But why would anybody, okay, I love earrings, I love jewelry, but why would anybody want, like, dental jewelry?
Well, I could, I don't wear jewelry, but I could, if I was going to have some, it would be dental. In fact, I'd like to make a set of boxers out of old gold crowns. So I'd like to encourage all the dentists in the audience to send in old gold, solid gold, preferably crowns.
Hey, I'd like to get on that as well.
No, no non-precious, please. Just solid gold for us, and we'll see if we can't make our own designer line of,
that would be incredible.
Of dental undergarments. Anything else?
Yes. Imagine going into surgery for your legs and coming out with 5 of your teeth missing. A 6-year-old UK girl suffers from a bone disease and went in to have metal rods inserted to make her limbs stronger, but surgeons removed 5 of her teeth while she was under. The hospital says the teeth posed a serious risk to her airway during surgery. They also say that the parents were made aware about all the care she may have needed, but the parents disagree. The hospital claims the teeth removed were all baby teeth, but the father says 2 of them were adult teeth. No action has been taken against any staff members, and the hospital is currently reviewing the matter.
Well, this is, I think, a miscommunication.
Yes.
And my experience has been that 9 out of 10 times, maybe 10 out of 10 times, the patient's wrong, or the patient's parent's wrong. You hear stories about, oh, he pulled up my wisdom teeth, he had his foot up on my chest, or, just you hear these
Craziness.
insane kind of stories that they'll tell you, oh, I had 9 wisdom teeth they had to take out. And where patients get this mixed up, I'm not sure. It's got to be they were all deciduous baby teeth. Back and forth, just kind of hanging on by a thread where the anesthesiologist is terrified that you knock one of those out, intubating the kid, something happens, they inhale it into the lungs. That's serious trouble. And so, they take out dentures, they take out partials. If there's anything remotely loose, they're going to take it out at that time, especially if they're just baby teeth holding on. I doubt they had oral surgery forceps there to be able to grab it. They must have just been able to take them out barehanded, and you're not getting a permanent tooth out barehanded.
Definitely.
You would have to go in and do surgery
Of
to
course.
take any kind of permanent tooth out that was halfway in. When you see number 8 and 9 coming in a kid, it's like, 9 times as large as the baby tooth that was there preceding it. I think the parents are totally confused. We'll wait and see how it all shows up, but I will not be shocked at all if it turns out they were all baby teeth and taken out for the health and well-being of the patient. Add up whatever it is, how much money it would have been for the 5 teeth for the tooth fairy, put it under the hospital pillow, when she's waking up from the leg surgery, whatever she had done, be thankful that she's happy and healthy, and say, oh, by the way, the tooth fairy came while you were knocked out because you're too much of a wimp to take these out yourself, or these teeth would have been gone instead of wagging back. My kids were kind of the same way. I mean, there came a point where I just had to say, look, you get these out, or the tooth fairy. If I take them out, I get the money, not you. And that was all the motivation they needed to tear it out, and it hurts for half a second. And kids today are wimps compared to how tough we were. And when I say we, I mean me and not you. I put you on the wimpy side because of your young age and my advanced age. That about wraps it up for this edition of Chairside Live. On behalf of my old self, the very young Megan, and all of us here at the laboratory, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time.
So you're telling me if I had a bra made up of David Beckham's teeth that you would not wear that?
No, that is so weird.
David Beckham, you heard me say Becks?
The Becks, yes.
You professed your love for him
The
on
Becks.
an earlier show.
I did, and the love still stands, but here's the thing. I don't like anatomy jewelry.
Okay.
Or anatomy...
All right, how about this? How about a shirt made of David Beckham's old dental floss?
Ew.
Trick question, David Beckham doesn't floss.
Okay.
Even grosser.